Hello everyone, happy morning, a very good morning. I hope and I believe all of you are doing well, and I hope you had a good peaceful sleep, not thinking too much about how the exam was. Yes, it was a bit eccentric, it was different from the routine NEET PG exam, but whatever is done, right? We cannot change it, so let's just not think a lot about it. So why are we doing the recall sessions is not to make anyone feel bad that, oh, you made a mistake in this question. It's just to learn, right? Learning should never stop irrespective of whether the exam is done or not. So that's why we are here. So first, let me just quickly check the live chat. Just a minute. Right. So let's start. What we are going to do in this today's session is we are going to do the radiology questions. We had 2 shifts, so the number of questions are also more. And anywhere, like, you know, in this year's NEET PG exam, we did see a lot of radiology questions integrated with other subjects, like, so basically they were clinical STEM questions with the radiology images also given. And the radiology images per se, if you ask me, yes, they were on the difficult side. They were not like straightforward. Many were straightforward, but there were few questions which were actually difficult ones, and I would honestly say that that is not expected from an MBBS graduate to know, but like 2 to 3 questions were definitely like that. Okay, so let's start with the discussion. Yeah, it is radiology recall only. Before like I forget, and I to tell you about the biggest news that we have here upcoming, that we are launching Rapid Revision 6.0 along with English videos on 16th of August. So this is not for the people who have already given NEET PG 24 exam, guys. This is not for you, because I want each one of you to clear the exam and be on the other side. This is for the upcoming batch, but just that I before I forget, so I wanted to make sure that I let them know at the outset. And in the rapid revision videos, there are going to be 260 plus hours of video lectures in both English and English, coupled with 2500 high yield MCQs, like the must practice MCQs, and along with concise notes. So I hope the future batch is really excited about the launch of Rapid Revision 6.0 along with the English videos, right? So let's start with the recall, and the purpose of this recall is for learning. One, and to get the actual questions from you guys from the inputs also. So let's start with it. The first question here, right, in radiology questions, if you ask me, the morning and the evening shifts, there was a lot of overlap in the topics, the area where the question was asked. So for example, right, in the morning shift, there was this question on thymoma. Then in the evening shift, there was a question on that was teratoma. Right, there was a double ring sign in the morning, the foreign body esophagus, the coin in esophagus was there in the evening shift as well, right? So there was an overlap there. So what I've tried to do is, yes, Ishrat, I've tried to put the morning shift questions first, and then we will discuss the second shift question, so as to segregate, so that someone who has given a morning shift will know that all these were the questions asked, so that you do not get confused ki ye wala question to maine dekha hi nahi, did I skip that question, right? So I've tried to segregate it. Okay, so let's start with this. So we are starting with the morning shift questions first, right? So first one that you have here is a 45-year-old patient who presents with ptosis, muscle weakness. I think the diagnosis of myasthenia gravis was also directly given there, like a patient of myasthenia gravis was there, right? And the has engorged veins was given, right? Myasthenia gravis along with this mediastinal mass, that was a major clue there. That means it's going to be thymoma. This is the anterior mediastinal mass along with the history of myasthenia. This becomes thymoma. Okay, so the answer here is going to be thymoma. That was a major clue there. Going to next one. Here also the history was given of a 6-week-old, right? A 6-week young child. So the 6-week was very important there. Vomiting was there, non-bilious vomiting, 6-week. So in that case, the ultrasound that you are seeing, remember duodenal atresia presents early. right? It does not wait for 6 weeks to present. So this is going to be CHPS. CHPS, like let me decode this image for you. And what is the image showing is, this is the part of the stomach that is there. You are seeing this all black because stomach is containing air. Remember on ultrasound, air shows shadowing. This is the elongated thickened pylorus that we are seeing here. Okay, and this is the liver here. So this is the elongated thickened pylorus, right? This is going to be CHPS. Okay, so the answer for this question is going to be CHPS. Correct. Going to next one, like there was question on subarachnoid hemorrhage in the morning shift. There was chronic SDH in the evening shift, right? So another overlap of the topics there. So an image was given along with the CT angio image was also given, something similar to this but not exactly this, where the aneurysm was seen and the subarachnoid hemorrhage was shown, right? The blood in the cisterns and the sylvian features. So this is going to be subarachnoid hemorrhage due to aneurysm. If you look at the rest of the options, they also gave you other options like subdural hemorrhage due to aneurysm, and the question itself, I mean the options itself are not matching. Like SDH is not because of aneurysm. Aneurysm causes SAH only. So that was the answer there, SAH due to aneurysm. Right, Shweta? Thymoma was not in the second shift. It was teratoma in the second shift. Okay. Going to next one, the morning shift question, foreign body in the esophagus, what sign is it? Obviously, you can rule out the rest of the signs ki steeple sign to nahi hai. Steeple sign laryngotracheobronchitis group mein hai. Thumb sign nahi hai, epiglottitis mein hai. So that is double ring sign. This is like one of your recent I9CT exam question where the foreign body was asked. What was that? The button battery. राइट I9CT क्वेश्चन वाज कि आइडेंटिफाई करो कि ये फॉरेन बॉडी कौन सी है, कॉइन है कि बटन बैटरी है कि कोक बॉटल का ढक्कन है. So that was the button battery, and when we did the recall for that, we discussed that button battery is something which shows double ring sign because of the two circles, the cathode and the anode, right? It shows the double ring sign. You take a lateral x-ray, it shows a beveled, a sloping edge, right? Because the two circles are of different size. So this is going to be double ring sign. Okay, this is going to be double ring sign. Is this clear with everyone? Yes. Next one, right? This was, now see, in the morning shift particularly I have discussed the easy questions first. Abhi jo controversial questions hai, difficult questions hai, wo abhi aa rahe hain. So do not jump to the conclusion ki morning mein sab kuch easy tha, right? It was not like that. Okay. Now this was a patient with respiratory distress and recurrent respiratory infections, right? It is not fitting even clinically. If you see, it is not fitting into the history of lung abscess, the high grade fever वगैरह दिया हो, and this is going to be CPAM, right? A congenital lung malformation where you would see, remember, it can be microcystic, it can be macrocystic. In the ultrasound, this sort of image was given. So this is actually the antenatal ultrasound image that this entire lung, this is the heart here. Okay, the lung is appearing echogenic because of the microcystic CPAM. Right, the microcystic will have this echogenic appearance. Then on the radiograph, there was something like air jaisa black color ka. So if your concept of black and white of radiology is clear, right, you'll be able to make out कि हाँ ये कुछ air related है. और फिर CT scan में image दिया गया था, ऐसा वाला image था, right? So this is congenital pulmonary airway malformation. Okay, this is going to be CPAM. It's a congenital lung malformation. It is not congenital diaphragmatic hernia. Remember, is more common on the left side. Okay, and this is more common on the, if you see on the right side, then you think of CPAM. And anyways, you are seeing the diaphragm very well. So it was CPAM. Going to next one, this was bit of a controversial, but again I think the clinical scenario, the history that has been given helps to make a diagnosis towards saccular aneurysm of the distal arch of aorta. This is not the exact image, but something like this was there in the exam, though this is not the exact image there, right? There was this bulge sort of thing which was present on the aorta, and that was suggestive of aneurysm. It was not a dissecting aneurysm. There was no division of the aneurysm into two, right? So precordial chest pain was there and hoarseness of voice. So remember that the aneurysm of the arch of aorta, because of its mass effect, and below the arch of aorta you have their recurrent laryngeal nerve, the left recurrent laryngeal nerve, that is probably causing the hoarseness of voice. So if you correlate something causing mass effect on the recurrent laryngeal nerve causing hoarseness of voice. So it's a mass lesion there. So it is going to be aneurysm. There was no dissection there. So it is saccular aneurysm. Okay, it was saccular aneurysm. Yeah, there was also the history of 1 month. कोआक्टेशन ऑफ एओर्टा में रिलेटिवली द हिस्ट्री वुड बी मोर पहले से आएगा, चाइल्डहुड में आएगा, है ना. सो दिस वाज बेसिकली कोआक्टेशन ऑफ एओर्टा नहीं था, सैक्युलर एन्यूरिज्म ऑफ एओर्टा. Going to next one, again this was very controversial type of question, right? Ambiguous question, but again few pointers here which is there, and just do not go by this appearance of the spiculated or the hair on end appearance of the bone, which was shown like this. Remember that hair on end appearance or the sunburst appearance where it is more divergent, both of these come under spiculated periosteal reaction. It is not specific for anything. All that it indicates is that the bone pathology that you are seeing is an aggressive pathology. Okay, that's an aggressive pathology. So that includes Ewing's also, that includes osteosarcoma also, and that includes osteomyelitis also. Right, and you had all the three in the options, and that is what made this question very controversial. Giant cell tumor to chale hi gaya, kyunki giant cell tumor is epiphyseal. Okay. So this is, now again this was 18-year-old. This was not even like 3-year-old, 4-year-old, 5-year-old to put it directly into Ewing's. But what I believe is the other history which is fever hai, tenderness hai, bone warm hai touch karne ke liye, ESR bada hua hai, and this was also given that the CRP was also high, right? Ewing's sarcoma also can mimic osteomyelitis, that is what we know. But I was trying to look into the literature, and one of this that I found that a high CRP level, apart from that is penumbra sign jo MRI mein hota hai, apart from that a high CRP level should support the diagnosis of osteomyelitis. So the question did mention that CRP is high, so I believe the answer should be osteomyelitis, but again, we really do not know with what intent the examiner has put this question, right? Osteosarcoma तो एक है जो मैं rule out कर दूंगी depending on the clinical feature कि fever है, bone warm है, tenderness है, ESR high है. Ewing's sarcoma does mimic osteomyelitis, but particularly when the high CRP was mentioned, maybe that was a difficult twist there in the question कि CRP high है तो आपको osteomyelitis mark करना है, right? That's just my thought process is what I am thinking. ESR high दिया था, right? Even in osteomyelitis also ESR is high, CRP is high. If you would look at the literature, even in Ewing's sarcoma, the CRP can be high and it's a poor prognostic feature. So like I said, I would rather put this question into a controversial question. CRP was given in the question as far as I remember, CRP was there, right? Next one, coming to other images, like this was the image given which was posterior urethral valve, the dilated posterior urethra, the posterior urethral valve, and the management was asked. So if you look at the type of questions, it was not just like we pellet diagnose, direct diagnosis karo, it is integrated with the surgical management and all. So remember posterior urethral valve, they did mention you that ki urinary catheterization last time bada easy tha, and that's what you see with PUV, right? If you go from down to up, the valve will open and there will be no obstruction. If something is coming from above down, the valve does not open. It's a one-way valve. So it will not open, and that is what leads to this dilated posterior urethra, keyhole appearance. And remember, for valve, if it's a valve causing the obstruction, what you need to do is remove the valve, right? So surgical removal of the valve is what needs to be done. Okay? Next one. Right, again a question which I will definitely put it as a difficult question for MBBS graduate, right? What I believe as an MBBS graduate, radiology, what you should know is emergency radiology wala ki, you know, hemorrhage kaise identify karna hai, infarct kaise karna hai, ya pulmonary embolism, something which is basically, you know, life-saving, and we all should know as MBBS graduates. But then going into the depths of topics like this is a bit difficult. Yeah, so this is correct. What do you think? This is compression fracture, chance fracture, burst fracture. These were the various options which were there. So this is a chance fracture. Okay, the difference between the compression fracture, which appears wedge shaped, जो यहाँ पे भी wedge shaped जैसा लग रहा था, right? And the difference between the compression fracture and the chance fracture is, remember, chance fracture is also horizontal. Now there was this lucency involving the posterior element also. Okay, there is fracture involving the posterior element also, and that is why this will go in chance fracture, not just the compression fracture. Okay, so this was chance fracture, right? Next one. Now there was this MRI, so ortho radiology integrated. The previous one was also like that. This is also like that. So there was this image of MRI showing the disc bulge, and they asked you कि कौन सा nerve root affect होगा. So when you are given such question, all you have to do is, see, ideally this is not the correct way of counting the vertebral level. When we do MRI spine, we take the entire spine and we start counting from above, cervical से. क्योंकि बहुत बार क्या होता है कि यहाँ पे sacralization है. We never know that whether what looks at S1 is actually L5 because L5 can be sacralized. But अगर आपके एग्जाम में आ रहा है इमेज ऐसा आ रहा है, you don't have an option. So you have to take this one as the sacrum is starting. S1 यहाँ पे start हो रहा है तो उसके ऊपर वाला ये L5 है और ये L4 है. So there is this L4, L5 disc which is compressing or which is impinging on the nerve there, right? So remember that when there is L4, L5, यहाँ से जो nerve traverse हो रही है, understand this one here. So look at the image here. जब L4, L5 है, you will have the L4 nerve root which is exiting, which is going out, and you would have the L5 nerve root which is traversing. Okay. So look at this disc level here. When you have this disc which is bulging, the most common which is affected here is going to be the L5. So remember जब L4, L5 है तो L5 affect होगा. L5, S1 है तो S1 affect होगा. Okay. So similarly here, look at this L4, L5, the nerve which is traversing, that is going to be the, this is going to be the L5. Okay. This is going to be L5. Until and unless the disc bulge is in a fashion which is foraminal extension, then it will cause the exiting nerve root which is affected. Otherwise, the most common is the traversing nerve root. Okay, the traversing nerve root. So in the image, they gave you this L4, L5, right? So that is why it is going to be L5 nerve root which is going to be affected. Okay, L5 nerve root which is going to be affected. Okay, clear with everyone? ठीक है. Chalo. So those were the questions from the morning shift that we had from radiology, plus there was one X-ray. Actually, it was ENT integrated question. These two were ortho integrated questions. PUV वाला एक DJ stent वाला क्वेश्चन था, वो सर्जरी इंटीग्रेटेड क्वेश्चन थे. एक जो ENT इंटीग्रेटेड क्वेश्चन था जो हमें कॉक्लियर इम्प्लांट वाला पूछा गया था. एंड रिमेंबर कॉक्लियर इम्प्लांट में जो मार्क किया गया था, दैट वाज द ground electrode. Okay, that was the ground electrode was the answer to the question on the cochlear implant. ठीक है? चलो. No, that was the ground electrode. Okay, the ground electrode. Now going to the evening shift के some questions, right? And here you guys, you need to give me the inputs on this. So first one here, I think this was easy. Where on the radiograph you see this white calcification, right? Look at this one. The white calcification here, remember this is the location of pancreas. We have seen this in our main videos also, right? So pancreatic calcification is what is there, and whenever there is pancreatic calcification, you will think of chronic pancreatitis, chronic calcific pancreatitis. Okay, so this is chronic pancreatitis, right? Next one. This is the MRI which was given and you had the various options here. So if your concept is clear of these disease pathologies, you know what does Chiari stand for, if you know what does Dendy-Walker stand for, what does vein of Galen malformation stand for, you would be able to rule out the options and then come to the answer. Remember, in image-based questions, ruling out is the best. When I cannot come to the answer directly, I rule out the options. That Chiari 1 malformation is basically small posterior fossa. And because of the small posterior fossa, there is no space. So the content will go down. So there is going to be tonsillar herniation, peg-like tonsils that will be there. Dendy-Walker malformation on the other hand is a large posterior fossa. Because there is a large posterior fossa cyst, right? Am I seeing any posterior fossa cyst here? No. Vein of Galen malformation comes here beneath the splenium of corpus callosum. Midline में यहाँ दिखेगा, that's a AV fistula, even that we cannot see, so they are out. Corpus callosum we can see, it's not corpus callosal agenesis, this is going to be Chiari 1 malformation, where you would see that ये जो foramen magnum का level है उसके नीचे you can see the tonsillar herniation, the peg-like tonsils basically which are going to be there. Okay, the peg-like tonsils which is going to be there. Is this clear with everyone? Yeah, chalo. Going to the next one. Now again a patient of acute pancreatitis is given and a chest x-ray is given. Now this is very very common association which is asked in the exam. Pancreatitis with the chest radiograph, you see bilateral opacities, it's going to be ARDS, right? ARDS is nothing but this is also called as non-cardiogenic pulmonary edema. Okay, this is non-cardiogenic pulmonary edema, so that's going to be the answer here. Is this clear with everyone? Yes, simple drawings, correct. So this one where you had the CHPS wala question, it had midgut volvulus as the option. So this is ARDS, non-cardiogenic pulmonary edema. Okay, non-cardiogenic pulmonary edema. Next one. Okay, drug history was given and 2 liters of fluid was infused. So whatever was added, it just remains, the answer remains the same, ARDS, non-cardiogenic pulmonary edema. Next question was pulsatile tinnitus mentioned in the question. अगर pulsatile tinnitus mentioned है तो आपको पता है कि वो glomus ही होने वाला है, acoustic neuroma नहीं होगा, otosclerosis नहीं होगा, glomus है, tympanicum है कि jugular है. Was something given here related to a mass seen in the ear or something else? Right? So whether it is glomus jugular or it is glomus tympanicum, again, you know, I think the questions did test a lot of basic knowledge and understanding also. Right? And the paper was very similar to the type of questions which were asked in the recent NEET exam also, you know, where the MCQ solving skills, the foundational concepts do help you a lot in ruling out the options. Okay? So they clearly mentioned that it was in the ear. So in the ear, of course, is going to be glomus tympanicum. Jugular ear mein nahi hota hai, right? That's related to the jugular foramen. And even here you can see that ye external auditory canal hai, black air containing wala. और ear के अंदर mass है, so this is going to be glomus tympanicum. Okay, this is going to be glomus tympanicum, not jugular. Next one, identify the investigation. If these were the options there, an absolutely controversial question. Fluoroscopy, barium swallow. Basically, barium swallow is done under fluoroscopy. Fluoroscopy is nothing but video x-ray, and in that video x-ray we do a lot of investigations like DSA, barium swallow and other investigations also. Right? So I think again this should go into a controversial question. You know, putting the options like या तो investigation identify करो या alkali या acid ingestion identify करो. Right? The options are very very vague. So the best answer here, if you narrow down, you should go with the barium swallow. Okay, barium swallow, correct. So remember, barium swallow we start, it's a esophagus. So esophagus starts in the neck itself. So remember, the jo neck ka image tha with the contrast image in the esophagus. This is going to be barium swallow. It shows you the hypopharynx, then the upper cervical esophagus, then niche ka esophagus. So just because it was a neck image, do not get confused. This is going to be barium swallow. Okay. Right, next one, not really sure whether this was there in the exam. Okay, was this question there? In the evening shift, was this question there? And ring enhancing lesions were there. Was this question there, guys? Right, so if they are showing you these multiple ring enhancing lesions like this, okay, multiple ring enhancing lesions like this. So as a radiologist, the two differentials that we think of, these small ring enhancing lesions, it's either like a TB or NCC. And as a radiologist, the first thing that we do to differentiate the two is MR spectroscopy, right? Because TB will show the lipid peak and NCC will not show the lipid peak, okay? So image was different, not sure. Okay, so this is going to be MR spectroscopy, right? If it was a ring and just one ring enhancing lesion, then you have some tumors also coming into play. Again, the MR spectroscopy will help you to differentiate कि अगर choline peak आया तो वो tumor है, lipid peak आया तो वो TB है. So it helps you narrow down there. Okay. All right. Okay, got it. Next one, MRCP image was given. Was the image something like this, which showed the dilatation of the CBD? If the dilatation of the CBD was there, this is going to be a choledochal cyst. Okay, that's going to be choledochal cyst. Okay. Right. Coming to next one, a patient presents with a foul smelling sputum along with breathlessness. So what do you see here? I think there was another image. इसमें at least आप ये देख रहे हो कि ये air containing black color का है और dependent part में नीचे यहाँ पे white fluid भी है. So whenever you have a lung lesion with air fluid level, it is going to be lung abscess is the first thing that you think of. Especially when you are given this history of foul smelling sputum also and along with fever, you think of lung abscess. ठीक है? Yeah, so this was image गलत हो गई है यहाँ पे. ठीक है. I think we had a renal cyst का image. Okay, the image has got interchanged. This is the image for the lung abscess. What was the image on the renal lesion? Renal lesion. Was it a renal cyst given there? Was it a renal cyst, a simple non-enhancing lesion? Multiple cyst. So, multiple left renal cyst, multiple cysts the, so you will go with polycystic kidney disease, right? I need to have a look at the image for that. Okay. Going to next one, a similar image was there in the evening shift and they also mentioned you that the HU value is minus 62. Yes, if I'm not wrong, that there was an image of a mass with the HU value given of minus 62. We have always discussed this, that negative HU value is fat and air. Air is minus 1000, fat is minus 50 to minus 100. So a fat containing mediastinal mass, remember you think of teratoma, it also contains white calcification. So when you have fat and calcification together, you think of teratoma, right? There's a dermoid. It is not only in the ovary, right? It can occur anywhere in the midline. So that is going to be teratoma. Okay, the answer there is going to be teratoma, a mediastinal mass. Okay, fat and calcium was there in the option itself. So from the HU value, you know that it's a fat containing lesion. Okay, so that makes it even easier. When you don't have to make a diagnosis, it was already given in the option. Anterior mediastinal mass with fat and calcification. Great. So that makes it relatively easy. Right, going to next one, this image was there where you have this sickle shape, S for sickle, SDH, and it was dark. So it was chronic SDH which was there. Again, a very important concept that we have always discussed, acute hemorrhage is hyperdense, chronic hemorrhage is hypodense, right? And the shape of the hemorrhage, that is going to be chronic SDH, okay, chronic SDH. Okay. Right, was there some image like this, a cellar, supracellar mass? Were you asked just the diagnosis, or this was the same question which was integrated with the visual field defect, that was bitemporal hemianopia? Any cellar, supracellar mass will cause bitemporal hemianopia, right? So this one, where you have a supracellar mass, this is the black one is the sphenoid sinus. You have the cella here, predominantly supracellar mass with this cystic areas, right? You have the pituitary gland here, cellar, supracellar mass, cystic areas. Remember, this is craniopharyngioma. Okay, craniopharyngioma. Remember the CCC for craniopharyngioma जो हमने discuss किया है कि generally child में होता है, center में midline में होता है, calcification भी होता है इसमें, cystic component भी होता है इसमें, right? So all of this is there. Okay, so one was that motor oil fluid wala, that is also craniopharyngioma. This is bitemporal hemianopia. Okay, yes, thank you Lokesh for reminding. In the morning shift, there was also the image of anencephaly was also there, right? So anencephaly was another image that was asked in the morning shift. Ultrasound image was given, that was anencephaly. Okay, right. Going to this one, an image something like this was there where they asked you hydrosalpinx hai, endometriosis hai, kya hai? Yes, A3, I'm coming to the next your doubt also, another ring enhancing question. Yeah, So this is when you see black on ultrasound. What is black on ultrasound? Remember, black on ultrasound, this jet black on ultrasound is fluid. So you know that this is something cystic. And in the cystic lesion, you are seeing this incomplete septations. This is something that we have discussed in the main videos also. So this is hydrosalpinx. Remember the fallopian tube which is there. It shows these incomplete projections, septations, incomplete septations जैसा appearance, cogwheel appearance. This is hydrosalpinx. Okay, this is hydrosalpinx. ठीक है? देखो, if the image had this septation wala appearance, then it is hydrosalpinx. If it is a follicular cyst, it will be within the ovary and it would be just a round cyst, like without any septations in that. If the septations were present, then definitely it is hydrosalpinx. Cogwheel appearance अगर दिया गया है, cogwheel appearance, cogwheel tells you those spokes जैसा appearance, the septation, the cogwheel is hydrosalpinx. Okay, cogwheel is hydrosalpinx. Yes. Okay, the same image was given. All right. So this is hydrosalpinx for sure. Okay, so these were the questions. और जो एक और क्वेश्चन आप बता रहे हो कि जो another ring enhancing lesion जो evening shift में पूछा गया था, another ring enhancing lesion image was there in radiology. Along with that, there was restricted diffusion, peripheral restricted diffusion. Again, something that has been discussed in the videos, right? So a ring enhancing lesion with a peripheral, central restricted diffusion. Sorry, right? Why central restricted diffusion? Because the thick pus in the abscess, that is what we have learned, कि जो abscess के अंदर thick pus है, वो move नहीं करेगा, तो वो restricted diffusion दिखाएगा. And when you give contrast in a patient of abscess, only the wall enhances because the pus in the center is dead. Right? It's a dead tissue basically. So it will not enhance. So ring enhancing with central restricted diffusion, that is going to be brain abscess. Okay, the answer there is going to be brain abscess. That's classical of brain abscess, right? Diffusion, DWI image. ठीक है, urethral stricture था, तो वो urethral stricture वाला image था. From a radiologist perspective, I'll tell you कि yes, it was urethral stricture. The management will be discussed in surgery. ठीक है? So I think we have covered the majority of the radiology questions, and I think one more image in the second shift was also what is marked there. The tibial tuberosity wala jo image tha, what is marked as the tibial tuberosity, X-ray knee was given, right? So that was another question there. Was there a question on spondylolisthesis? This is a repeat actually, has been asked in the previous exam also. Spondylolisthesis. मल्टीपल रेनल सिस्ट है तो आपको पॉलीसिस्टिक किडनी डिजीज करने पड़ेगा. इट हैज टू बी इन बोथ द किडनीज फॉर दैट, और इवन द वन किडनी में यू हैव दैट एज वाइज क्राइटेरिया फॉर पॉलीसिस्टिक किडनी डिजीज. Okay, so right, some lessons that we have learned from NEET PG 24. The pattern definitely is moving towards more clinical integrated questions. The pattern is shifting from your just fact-based one-liner questions to clinical questions, though of course memory retention becomes very important whether you are solving those one-liner questions or the clinical questions. But when you have the long-stem clinical questions, you need to have a lot of MCQ practice. How to read the questions fast, how to read in between the lines, how do you jump to the answers quickly, because time management was very important. I did get some messages where the students said that they found the exam very lengthy because all the questions were like lengthy pattern, and that just implies that somewhere the MCQ practice was lacking, right? So MCQ practice is very, very important. There was a lot of overlap, I believe, between FMG, NEET PG and INI-CT questions, right? So it had some repeats from FMG also and from INI-CT also. So now when you prepare, not you guys, because like I said, I want each one of you to clear the exam. But when you want to give any advice or suggestion to your juniors, please do tell them that irrespective of whatever exam they are preparing, they have to look into the previous year questions and the PYTs of all the 3 exams, right? All the exams are now coming almost to the same level. Okay. Yeah, coin in esophagus was also there. CT thorax was asked, SAP wala tha. Okay. That anatomy was also there. Most commonly impacted in cricopharynx, the coin in esophagus, correct. Aorta, trachea, esophagus. Okay, so that was the another anatomy image question which was there. Okay. So I'll just add on to the list कि CD chest में anatomy वाला एक question पूछा गया था where SVC aorta was asked. And in the evening also there was this coin and esophagus question which was asked. Okay, calcified pancreas हमने देख लिया, ठीक है. So the radiology questions, if you see, majority were doable except for like few controversial questions, जैसे morning shift में वो osteomyelitis है कि एविंग सार्कोमा है. सेकेंड वाला वो जो एन्यूरिज्म, सैकुलर एन्यूरिज्म वाला इमेज थोड़ा सा डिफिकल्ट था, राइट. सो थोड़े से कॉन्ट्रोवर्शियल क्वेश्चन थे. इवनिंग में जैसे बेरियम स्वॉलो, फ्लोरोस्कोपी, एसिड एल्कली, ये कॉन्ट्रोवर्शियल एम्बिगुअस क्वेश्चन है. बट अदरवाइज the majority of the questions can be done, provided you've done it really well, your preparation has been very well, your concepts are very good, right? So that is very very important. ठीक है, चलो. So thank you so much everyone. That was about radiology recall. No matter how your exam has been, no matter how many mistakes you have made, remember you cannot change any of that. So just relax, just wait for the results, and you never know, other students might have done even worse than you. हम एग्जाम के बाद हमें लगता है कि हमारा ही सबसे गंदा हुआ है, राइट, बट पता नहीं है कि बाकी लोगों का और कितना गंदा हुआ है. सो लेट्स जस्ट वेट फॉर द रिजल्ट्स एंड बी होपफुल अबाउट द रिजल्ट्स. आई थिंक दोस शुड बी, द रिजल्ट्स शुड बी आउट सून, and then we can definitely take a decision on the course ahead. Okay, thank you so much everyone. Goodbye, take care, and no more keep studying and keep revising, right? Just keep enjoying and keep relaxing. Thank you so much.